morning, ladies and gentlemen. Welcome to the next presentation in the UCT-Africa virtual ENT academic presentations. My name is Simon Honnet. I'm one of the registrars at UCT. Just to go over the usual house rules is please stay muted during the presentation. Keep all questions for at the end. If you're not to raise a hand, otherwise put the questions in the chat function. And switch off your video because it interferes with the Wi-Fi. So for this morning, we've got a case presentation just as an introduction to the main meal. So the case is a lady, Mrs. W.S., who presented to our clinic last week. She's a 57-year-old lady who had been complaining for 5 years of painful lesions, initially on the lips, upper and lower lip, which had been cauterized by dermatology by her description. Her description was a little bit vague with it having been a few years ago, but it sounded like a cautery under local or topical anesthetic in the dermatology clinic. The lip lesions were then completely resolved, but she now had similar lesions appearing on the tongue. And the only past medical history of note was in June this year, she had had an episode of diverticulosis, which was successfully treated by the GIT department. We'll see later on why that is actually relevant. Socially, she's a non-smoker, non-alcoholic, and she works in an office environment, so obviously there's no exposure to toxins or chemicals or anything like that. So I won't ask for participation from the audience, but one would be thinking of what a differential diagnosis would be with that kind of picture. And luckily, the professor of dermatology had already given a diagnosis of a blue rubber bleb nevus syndrome, which is obviously quite rare. And the patient had been through many different departments after dermatology before coming to ENT. And so she was quite desperate for some help with how to manage these things. So that's the introduction into where does blue rubber bleb nevus syndrome fit in. So it's one of the venous malformations. So you can see on the left-hand side of the screen, vascular anomalies can be classified either as malformations or vascular tumors. And within the malformations, you've got venous, lymphatic, arterial, capillary, AV malformations, and AV fistulae, or combined with a combination of any of the above. In terms of vascular tumors, by far the most common is a hemangioma, but you do get others ranging from benign to malignant tumors. The other way of classifying it is on low flow versus high flow, where all of the tumors mostly are high flow lesions, and then the malformations are divided into high flow and low flow as well. So today's presentation will be a little bit on blue rubber bleb nevus syndrome, because that's what brought us to the topic, but also on hemangiomas, because that's by far the most common vascular tumor that we see, certainly in ENT. So it's topical for us. So just on there's a broad range of malformations and tumors ranging all the way from simple birthmarks to life-threatening lesions. And although there's two different classifications here, one nice quote in one of the references is that classifications should not be cast in stone, but rather should be written on recyclable paper, because they do change on a regular basis. So my references for the talk are, firstly, in terms of the classifications, there's ISSVA.org is a very useful website, and that's what the sort of the global classification system is using. In terms of the pictures, almost all of the pictures for the talk come from this very good color atlas of vascular malformations and tumors. Most of the management topics have been taken from up to date, so as to be still relevant. And of course, our recommended textbook, Scott Brown, as well. So unfortunately, with all these new classifications, there's quite sort of poor uptake of all of the new terminologies into the sort of medical world, and lots of people are still stuck on the old classification systems and terminologies. But hemangioma is said to be one of the most egregious examples of this, where it is a benign vascular tumor. There's many hypotheses as to the etiology, which I'll get to now, but basically the word hemangioma is also used colloquially and inappropriately. And even in the 2013 edition of the WHO classification of tumors and soft tissues, the word hemangioma is used incorrectly, according to the ISSVA classification system. So the recent increase in knowledge of genetic basis of many of these diseases is now contributing to the latest changes. In terms of historical perspectives, hemangiomas, for some people in our group, were previously thought to be caused by maternal misbehavior or infatuation, either during the time of conception or during pregnancy. And the word birthmark actually translates into envy in French, meaning a desire, or into voglia in Italian, which I'm probably mispronouncing, meaning a craving. Descartes, who was a French philosopher and able to sort of come up with the understanding of how to prove his and our existence by saying, I think, therefore I am, was a little bit off the point in saying that the image of a given object is sometimes transmitted by the arteries of a woman to one or other part of the fetus and imprints there marks known as birthmarks. So that was Descartes' theory. Boyle, who in 1744 was clever enough to describe the relationship between pressure and volume of a gas, is quoted as saying that a speckled child was due to the mother having gazed a little too intently at the red pebble stones in St. Winifred's well. So that was the sort of theories on hypothesis back then. Dr. Blondel, wanting to challenge this sort of current theory in 1727, wrote a paper in a prominent medical journal at the time, but couldn't even put his own name to it for fear of being sort of ostracized from the medical community. So he wrote a paper called The Strength of Imagination in Pregnant Women Examined, and the opinion that marks and deformities in children arise from thence demonstrated to be a vulgar error, but he couldn't even put his name to that for fear of castigation. So hemangiomas are the most common tumor in infancy, occurring in approximately 5% of term Caucasian babies, and even more than that in premature babies. The etiology is unknown. The epidemiology is very difficult to accurately record because there's so many varying uses of the word hemangioma and inconsistent use of the terminologies. But that's just what it is. So the classifications that are used are simple versus multiple, localized versus segmental, and even disseminated hemangiomas, superficial, mixed, and deep versus visceral hemangiomas, and lastly, and probably the most important, is congenital versus infantile hemangiomas. So there's an example. From here on, there's going to be lots of pictures from that color atlas, because picture paints 1,000 words, but that's an example of a multifocal hemangioma. When it comes to the different depths of hemangiomas, you get superficial hemangiomas, which arise in the dermis, giving it a bright red color. And on the other end of the spectrum, a deep hemangioma in the subcutaneous tissue, which appears more pale, sort of red or blue color, and sometimes even has completely normal skin overlying the sort of soft cystic mass. And mixed hemangiomas in between, you can see a superficial lesion on top of a deep lesion. Then, most importantly, is the distinction between congenital and infantile hemangioma. where firstly, the vast majority of hemangiomas are the infantile version. The onset in congenital hemangioma is obviously from the word from the beginning, or with the beginning, is present at birth, and basically never involutes. It stays throughout the patient's life, whereas an infantile hemangioma usually starts at birth. Some patients, in the case of a superficial infantile hemangioma, can present with the lesion already at birth, but often it doesn't look like a typical hemangioma. It often just looks like a red macule. So the differential for that would be a capillary malformation, because it's a flat lesion, it's not raised at all. But obviously, during the course of the infancy, would progress to a more typical hemangioma appearance. And that is only in 30% of cases, whereas deep infantile hemangioma is usually only present at a few months old, and grow from there a lot during the infancy. So the growth pattern and involution pattern goes through different stages of proliferation, stability, and involution. In a congenital hemangioma, the involution is classified, or the lesions are classified as rapidly involuting, non-involuting, and some people have even added a partially involuting congenital hemangioma, according to the time at which you can expect spontaneous involution without any treatment. In contrast, the infantile hemangiomas, the solid line over there, usually only present at birth, grow rapidly during the first year of life, and then start to involute slowly after that, but taking many years to spontaneously involute by a process of apoptosis. Clinically, congenital hemangiomas, the less common variant, are quite unvariable in their presentation. They're usually about 5 centimeters in diameter, occur much more commonly on the limbs than the head and neck areas. But the main sort of bread and butter of the talk is the infantile hemangiomas, which are very variable in presentation. Most commonly, it's a solitary superficial infantile hemangioma, but there's a lot of variation in that. And the symptoms obviously depend on the sites involved. So the common sites would be the orbit, lips and oral cavity, parotid gland, the nose, and even subglottis, where they can present with struggle. Importantly, hemangiomas do not infiltrate into muscles, but rather can sometimes infiltrate into the fascia between muscles or adjacent to the bone. In contrast to venous malformations, which includes the blue rubber bleb nevus syndrome from the case presentation, they can be intramuscular and they can cause bony erosion. And the significance there is just that some classical cases of venous malformations were previously incorrectly called hemangiomas. So that there's a bit of overlap in the terminology. For the importance for ENT is when you see hemangiomas, you must look out for 3 different sort of scenarios that can arise. Firstly, an infantile hemangioma in the beard distribution, as seen on the picture on the left. One should check for a subglottic hemangioma because that can present with stridor. 50% of patients with subglottic hemangioma have an associated cutaneous hemangioma, but of course there's many patients with cutaneous hemangiomas that don't have a subglottic hemangioma. So the point is just if you see it in a beard distribution, think about subglottic hemangioma. The next is if you see multiple superficial infantile hemangiomas, one should think of the possibility of visceral infantile hemangiomas in the liver, and one can check that with a liver ultrasound. The next one is if there's large, and they define large as being more than 5 centimeters, segmental infantile hemangiomas in the head and neck area, then one should check for Faces syndrome. So just to quickly say on the distribution of facial hemangiomas, specifically the segmental type, it's not a random pattern, but it is similar in a way to the embryological development and distribution, for example, of the trigeminal nerve, although with some differences, and that does then relate to some of the unproven hypotheses regarding the etiology. But basically, if you see a large segmental infantile hemangioma in the head and neck area, then Faces syndrome the P is for posterior fossa brain malformations, specifically Dandy-Walker complex, cerebellar hypoplasia or atrophy, subependymal and arachnoid cysts, cerebellar hypoplasia or agenesis, microcephaly or pituitary aplasia. The H would be infantile hemangiomas, but specifically that description. The A is arterial abnormalities, specifically of the cerebrovascular arteries, where they get dysplasia or hypoplasia or even aplasia, sometimes an aberrant origin and sometimes saccular aneurysms. The C is cardiac abnormalities, specifically coarctation of the aorta. The E is eye abnormalities with specifically microphthalmia and optic nerve hypoplasia. And the S was added later after the original description of just face. And there's two possibilities for the S. It can either be a sternal defect or a supraumbilical rate. So if you see that sort of cluster of a syndrome, one can check. The investigations would be an MRI of the brain and neck, a cardiac echo, and a referral to ophthalmology. So that's the three sort of scenarios that we encounter in ENT. In terms of imaging for hemangiomas, many vascular anomalies can be accurately diagnosed simply on history and examination, not requiring any imaging. So imaging requests should be specific and indicated according to the clinical context and not a one-size-fits-all approach. But if imaging is needed, then MRI certainly is the gold standard imaging modality for any vascular tumor or fast flow vascular malformation. It can identify and is usually diagnostic for the lesion, also shows relationship of the lesion to adjacent normal vessels and nerves, which may become relevant for subsequent treatment options. And fast flow lesions appear as flow voids on most sequences. But if you get a flow void, then you can always ask them to do an MRA. Sometimes the imaging results are quite unexpected, like you see in the picture on the left, what appears to be a small superficial infantile hemangioma actually turned out to have a large orbital component that was basically unexpected. Plain X-rays are of limited value. You may see phleboliths, or in larger lesions, you may see bony erosion. But if you had any of those features, you would end up getting a scan anyway. Ultrasound and Doppler has been used and does have some role to play. It may distinguish vascular malformations from tumors. You can see if there's a solid component or is it completely cystic. And you can see fast flow versus slow flow lesions using the Doppler function. Then a CT scan with contrast is also of limited value, partly because of the risk of the ionizing radiation in childhood, except CT with contrast is useful in macrocystic lymphatic malformations, where the cysts are clearly defined and a CT is often adequate for management. Then in terms of treatment for hemangiomas, there is a role obviously for watch and wait. If you think of that growth curve where many hemangiomas spontaneously involute without any treatment, there's a role for a watch and wait, as long as the lesion is in a safe area and there's no cosmetic or functional defect. That's three pictures of the same patient over time showing complete involution of the lesion. Medical treatment would consist firstly of corticosteroids as being the first line of treatment, and we'll get to the indications, but basically oral prednisone in high doses of 2 to 3 milligrams per kilo per day, tapered slowly over a few months, would be the first line. Intralesional steroids have been used as well, each 4 to 6 weeks for 5 doses, and that would be used for hemangiomas around important sites. So where it's around the orbit, the tip of the nose, lips, larynx, or trachea, where it's causing or at risk of causing functional or life-threatening complications. The side effects, however, of steroids are well known: irritability and insomnia, gastritis and reflux, Cushingoid facies, slowed growth of cataracts. Also, the outcome is not as great as one would like. The steroids have been shown to mostly just stop further growth, but the involution of the lesion still occurs at the same time that you would have expected it anyway. But because the side effect profile of steroids is much better than the other medical treatment options, it is the first line of treatment. Topical steroid ointments have also been used for treatment as well, but there's currently no evidence to support their use, or no evidence to support replacing oral or intralesional steroids with topical steroids. So the options for other medical treatment in quote marks would be interferon alpha 2A or 2B, given as 3 million units injected subcutaneously daily for 6 to 12 months. So that's obviously a not entirely practical solution. Its use is limited by side effects of spastic diplegia in 5% of children receiving interferon alpha for hemangioma, which is quite a significant complication. It's quite a significant percentage of patients. Strangely, children receiving interferon alpha for chronic hepatitis don't seem to develop that complication, but it is a significant risk in the context of this lesion. Beta blockers, either propranolol or timolol topically, have been used in subglottic hemangiomas. Vincristine has been used 1 milligram per square meter IVI weekly for between 1 and 6 months. Obviously, there's risks with using those sort of agents, and bleomycin as an intralesional injection has been used with some concern of the toxicity if it leaks into the tissues and concern for pulmonary complications. So, because the side effects of those other medical treatments are more severe, they're kind of reserved for more severe cases. Specifically, a few examples would be multisegmental hemangiomas. So the segmental usually just involves one of the areas of the face, but if it's multiple areas, then the symptoms can be a lot more severe, impairing feeding, impairing vision, certainly the cosmetic deformity, and the risk of non-involution of the lesion. So that's a series of photographs of the same patient during the course of medical treatment, showing fantastic or fairly good resolution of the lesion. Multi-segmental hemangiomas that specifically impair feeding, or if they're complicated by ulceration, those would be less. You can start with steroids, but you would have a low threshold to follow that up with the other medical treatment options. Again, a series of photos of the same patient with considering the initial photos, a reasonably good outcome. The faces syndrome, as seen on the photo on the left, and the MRI of the same patient, showing orbital hemangioma, microphthalmos, cataracts, and optic nerve hyperplasia. They can also, so that patient with the faces syndrome was treated initially with steroids, failed to respond to steroids, so was treated with other medical treatment, and has a reasonably good outcome. And then lastly, if the hemangioma is complicated by heart failure, that's a significant enough complication to warrant other medical treatment. Obviously, in the context of other medical treatment, there's no good quality evidence-based medicine to support one agent over another. Firstly, because of the low number of patients with the lesions, and ethical issues regarding trials on children. So laser has also been used, as well as cryosurgery. The main risk with laser, however, is the risk of scarring of the lesion. Cryosurgery has been used, but with limited evidence to support its use. So then surgical excision is basically the last option if for failure of medical treatment. But that would be reserved for lesions that threaten the airway or have threatened vision. Obviously, if there's severe ulceration or hemorrhage from the lesion, for large pedunculated hemangiomas in areas of no cosmetic concern, that would be a good candidate for surgery. And then cosmetically disfiguring lesions on their own, you could say, are not really an indication for surgery, but if it's causing psychiatric problems and stigmatization, and there's no relief from psychiatric treatment, that may be an indication for surgery. And then obviously late repair of the residual defect after involution of the lesion would be an indication for surgery, but that does sometimes overlap with the role of plastic surgery reconstruction. In terms of the surgery for subglottic hemangiomas, these firstly often have quite a poor response to medical treatment with steroids. So they present with significant stridor and often need a CO2 laser and dilation of the hemangioma. With that, obviously, there is a risk of secondary stenosis. So the other option would be an open surgery with either laryngo or tracheoplasty according to the extent of the lesion and extent of stenosis following previous dilations, and sometimes with a cartilage graft as well. Usually, hemangiomas involute spontaneously with a fantastic cosmetic and functional outcome, but sometimes there are complications during the course of involution, including a painful ulceration, which sometimes starts bleeding and can get secondary infection, particularly if it's around the mouth or oral cavity or lips. Then you can imagine with feeding, it's going to be prone to getting secondary infection. The other complication would be that quite unpredictably, out of all the hemangiomas that involute, some of them are replaced rather by a fibrofatty sort of residual tissue and quite slack skin. That sort of outcome is completely unpredictable, and the defect is only cosmetic, but can be treated by plastic surgery. So in terms of the other vascular tumors, they're classified as benign, malignant, and then in between is locally aggressive. It's strange that Kaposi's sarcoma is not classified by the ISSVA as malignant, but rather just as locally aggressive, but that's their classification. But the important thing for ENT is that the tufted angiomas, which are quite uncommon, and the Kaposi-form hemangioendothelioma, those two in red, can be complicated by Kasabach-Merritt phenomenon. So that presents at birth or sometimes during infancy, usually before 5 months of age, and it's basically thought to be due to an abnormal trapping and activation of platelets in the abnormal endothelium, resulting in a consumptive coagulopathy, specifically and most importantly consuming all the fibrinogen. So that therefore results in a severe, profound thrombocytopenia, often with platelets as low as being less than 10. That obviously causes a bleeding tendency, specifically with purpura and spontaneous bleeding into the pharynx, GIT, and brain. The Kasabach-Merritt phenomenon is also characterized by release of growth factors that promote further growth of the tumor, which then obviously causes a vicious cycle and positive feedback to worsen the whole situation. And then in large lesions, you can get a significant amount of diversion of the blood through the tumor that can then result in cardiac failure. So the condition tends to worsen with infection, trauma, including biopsy and platelet transfusion. So one should be aware of that when biopsying vascular tumors that look unlike hemangiomas. There is the investigations needed would simply be an FBC, INR, PTT, and the treatment would basically be surgical resection of the lead of the tumor would be curative for this phenomenon, but specifically avoid platelet transfusions and avoid clexane, because those can worsen the whole situation by releasing growth factors for the tumor. Except obviously if there's a life-threatening bleed or immediately before surgical excision, then that is appropriate. So just coming back to our blue rubber bleb nevus syndrome, fits into the vascular malformations, and specifically a venous malformation over there. We've dealt with the hemangiomas and the other tumors. There's a lot of talk possibly on all the other vascular malformations, and specifically lymphatic malformations, the old-fashioned cystic hygromas, but that's going to be a whole other talk on its own. So to get into the blue rubber bleb nevus syndrome, that occurs usually sporadically in men and women equally. It's usually present from birth, increasing in the number of lesions throughout adulthood and throughout life. They are multiple, well-circumscribed venous malformations on the skin, including the palms and soles. You can also get venous malformations in the GIT, most commonly in the small bowel, which can present with melena, hematemesis, hematochezia, and iron deficiency anemia. And other visceral sites are less commonly involved, but can occur anywhere else in the body. So to come back to Our Lady, Mrs. W.S., she had an episode, a past medical history of diverticulosis, which is characterized by lower GIT bleeding. And one does then wonder if this was possibly related to venous malformations in her bowel. The treatment for blue rubber bleb nevus syndrome would be firstly watch and wait for small lesions if the symptoms are mild. In terms of active treatment, firstly the indication for active treatment would be any pain, functional impairment, or cosmetic impairment. And the options are elastic compression garments if it's in a suitable site of the body, which is not the case in Our Lady. Medical treatment, sclerotherapy, and surgical excision. So the medical treatment consists of either analgesics or low-dose aspirin, but then sirolimus is a newly used agent in the context of these vascular malformations, originally used for immune suppression to prevent organ rejection in renal transplant. Mechanism of action is that it inhibits the activation of the mammalian target of rapamycin, the mTOR. So it's targeted treatment specifically for these kind of lesions to prevent progression of the cell cycle and prevent activation of the lymphocytes which are involved in the pathogenesis. Its use is limited by side effects of mucositis being so severe that it requires stopping the treatment in as many as 10% of patients using it, which is a significant complication. There's a systematic review from 2019 that shows low-level evidence to support its oral use for patients, firstly with venous and lymphatic malformations, where 90% of the patients had reduction in size of the lesion, and secondly for Kasabach-Meret's phenomenon, where 90% of the patients had improvement or even normalization of the coagulopathy. Sclerotherapy is used basically as the first-line treatment for venous malformations, either with curative intent or preoperatively to reduce the bulk of the lesions before surgical excision. The options would be alcohol or bleomycin. Alcohol is highly effective, but it's also highly toxic if there's any spillage into the surrounding tissues, specifically causing neuropathy and skin necrosis. Bleomycin is less toxic if it's spilled into the tissues with regard to neurotoxicity, but there is a risk of a theoretical risk of pulmonary fibrosis. Any of these sclerotherapy options one would expect to require multiple sessions of sclerotherapy for it to be effective. In terms of preparation for surgical excision, one should always check the coagulation profile preoperatively, where a D-dimer level of more than 0.5 would suggest a localized intravascular coagulopathy, which would obviously be important to correct preoperatively to reduce the risk of intraoperative bleeding. The indications for surgery in pleura bleb nevus syndrome would be small, well-defined lesions where you can potentially completely excise the entire lesion for complete curative intent, or large lesions where surgery is made easier by firstly doing sclerotherapy beforehand to ensure complete excision of the lesion. Obviously, if there's a large defect after the surgery, reconstruction may be required with either a pedicle or free flap, fasciocutaneous or muscle flap, or a skin graft. And then for venous malformations in or around the airway, one should anticipate the possibility of needing a pre-op tracheostomy or post-op mechanical ventilation for between 2 and 3 days to allow the airway swelling to settle. So to come back to Our Lady, she's been through a multidisciplinary treatment sort of management, including dermatology, ENT, maxillofacial and oral surgery, vascular surgery, and plastic surgery has been involved. And we are weighing up the different treatment options, but sclerotherapy, because the lesions are small and easily accessible, sclerotherapy is probably going to be the best treatment option. Thank you very much. Does anyone have any questions?
Hi, good morning. Can you hear me?
Good morning, Professor. Yes, thank you very much.
Good morning to everybody. You know, this is very good. You know, hemangiomas are fascinating, especially of the head and neck, and because of their multiple presentations. And sometimes we don't know whether they are vascular malformations or whether they're true tumors, and they present a real challenge. There's two little things that I would like you to perhaps elucidate on, if possible, and I would like to make one little comment. What about the intra-bony hemangiomas? How do you approach this diagnosis and treatment?
Yeah, so Professor, that's a very topical discussion point from the ISSVA classification, is that the terminologies for specifically for hemangiomas have changed enormously over the years, and the current classification being used by this group says that hemangiomas of all types do not involve lesions inside bone. They don't erode bone and they don't occur within bone. So all those lesions that were previously called hemangiomas in that context have now been reclassified into the venous malformations mostly, and some other vascular malformations as well. But it is a very difficult sort of topic to grasp which lesions have changed their names and which ones have become what other description. It is difficult to keep track of. So I kind of used just that one classification system just because you've got to choose one.
That's fascinating. Sorry, can you just send me can you just post a reference of that article?
Yeah, well, so it's the International Society for Vascular Anomalies. So if you go to issva.org, it was in. Let me just see if I can share that. It is there. Yeah, so issva.org is the International Society for the Study of Vascular Anomalies. And that's quoted as being the sort of current classification system that's most widely accepted. And it's also, by the way, included in up-to-date. Up-to-date uses that classification system as well.
Right. Okay, but that's fascinating. Tell me, do you guys use ligation as well as a form of treatment?
Yeah, so I didn't go a lot into the surgical treatment options, but certainly ligation could be an option, specifically if you think of that tongue lesion. But the vascular channels in the tumors are, or in the malformations, are not normal vasculature. So one can expect that they're going to potentially bleed more than usual. But ligation could be one option, and electrocautery could be one option. But that probably shouldn't be done under local anesthetic. It should rather be done either general in theatre for that tongue lesion, because one would anticipate a significant risk of bleeding.
Yeah. Okay. Can I just ask you also whether you know what is the difference between a pyogenic granuloma and a lobular capillary hemangioma of the upper oral aerodigestive tract?
Yeah, certainly. So a pyogenic granuloma is kind of one of those terminologies like a cystic hygroma that was popularly used and even colloquially used decades ago, but the ISSVA is wanting to try and phase out. So like you said, a pyogenic granuloma has now changed its name to a lobulated capillary, lobulated hemangioma. But in terms of a difference between that and the other lesion that you mentioned, I'm not sure of any differences.
You know, gosh, that's complicated, because the thing is that I don't think that that term pyogenic granuloma will disappear out of the vocabulary of oral maxillofacial and ENT pathology as designating those lesions that are purely reactive and as reactive hyperplasia of granulation tissue that responds to local irritation. And you know that our oral mucosa and ENT mucosa is actually always tight over bone. So if you don't have a repair process, it can't actually go anywhere but exophytic. And that's why you see that a lot of injuries that are chronic or acute present as polyps that are then diagnosed as, that depends who actually diagnoses it. If you have an ENT head and neck pathologist, he will say it's pyogenic granuloma. And if it's a general pathologist, they will say it's a lobular capillary hemangioma, or they will just say it's granulation tissue. And the thing is that some pyogenic granulomas do really look like segmented lobular hemangiomas, which are exophytic and pedunculated. But the interesting thing is that both of them react to exactly the same treatment. In other words, you remove the source of irritation and they regress. Now, technically, tumors do not regress.
Yes, absolutely. Well, yeah. So just on the topic of nomenclature changing, this slide shows what would have previously been called a capillary hemangioma on the left and a cavernous hemangioma on the back of the neck on the picture on the right. But that's another example of terminology that they're trying to move away from. And obviously cavernous hemangiomas are now called visceral hemangiomas if they occur in the viscera, specifically the liver being most common. The terminology is keeping on changing.
Yeah, but that I can buy. But the problem that you're going to have in your career is that you will never find that there will be a consensus on the nomenclature of those exophytic lesions on the gums or the tongue or the cheek or wherever else there is mucosa-lined tissue. You can have intubation pyogenic granulomas of the vocal cords. And then they get diagnosed as hemangiomas. Now, what do you want to do about that? You want to consider it a hemangioma, or you say, well, I'll just watch and wait, or do I go and aggressively treat it? And I think that you need to be aware that you know, most of these lesions are reactive. especially when they're pedunculated and of short duration. But they can look like anything, hemangiomas, Kaposi sarcomas. So I think this is what might be confusing for the surgeon, is to get a report. What actually is a reactive lesion is called a hemangioma.
Absolutely, yeah. I'd also remember one case that we had in Red Cross of a child with what looked like a pyogenic granuloma in the nose, in the nasal cavity, and turned out to be a rhabdomyosarcoma.
Yes, because that, you know why that is? Because they all look similar. I've got lots of blood in them, so they look blue. And the other thing is also you can have pyogenic groma-like changes on top of other, let's say, exophytic lesions that are prone to exposure. So the granulation tissue that you get as a reactive to the trauma, that can be obviously mechanical in most of our cases, is then pyogenic tissue. And if that's biopsied, then it's called by some pathologists as a hemangioma. Yet the underlying pathology is not that. So that's why the confusion comes in, and that's why you say, oh well, we had this case, but as a matter of fact, what was misinterpreted as pyogenic, the pyogenic tissue that is there forming a reactive buffer layer over exophytic lesions is not a tumor. That is just a reactive tissue, and a lot of diagnosis of other lesions get missed because of the layer of pyogenic tissue that looks like hemangioma covering a lot of our lesions in the ENT area. So the thing is that you need to then ask yourself as a surgeon, now if I get a diagnosis of a capillary hemangioma with inflammation usually in what I really don't really expect it to be, just think twice and say, well, maybe this is just a misnomer. It's either granulation tissue overlying an area of trauma, masquerading the true underlying condition or tumor or whatever it is, or it is a reactive lesion on its own and it will disappear on conservative treatment.
It's a very interesting topic.
Yes, I know, but it's a topic of confusion. And I think a lot of pyogenic granomas have been overtreated. And also what you got to realize is once the trauma is being removed, most of these capillary hemangiomas that are so-called capillary hemangiomas will actually regress. And we see it in pregnancy as well, where they say, oh, it's a pregnancy granuloma, because it appears on the gum of pregnant ladies. So the only reason why it occurs is that the pregnant ladies do not often pay much attention to the gingival hygiene. So what happens is you get plaque, and the plaque irritates the gum margin, and the gum margin starts reactive with granulation tissue. It's exophytic. That looks like a pyogenic granuloma. Then it kind of matures quicker because there are growth hormones around, and it actually stimulates the lesion to become more solid, somewhat larger. And then when you biopsy that, then it looks like a capillary hemangioma, lobar capillary hemangioma. The moment the baby is the birth is over, and everything, and the person hormone status remains so normal, they disappear, they regress. Now you would not expect a capillary hemangioma to regress spontaneously if it's a tumor.
Yeah, thanks very much, Prof. Dr. Brownell just has an announcement as well, I think announcing the topic of the next talk.
Yes, good morning, everyone. Thank you so much. Thanks, Prof, for your contribution. Thank you, everyone, for joining us. I just wanted to make an announcement that on Friday, we will be having a Paint Africa presentation. We will have Dr. Clemens Jadisa joining us, and we're going to do a really cool talk on a few things. So we'll send out the link shortly, and we hope you'll all join for that. On that note, I'm going to need to end the meeting. Thank you all for joining us this morning. We'll see you soon.